Okay, so thank you. Yeah, so we've seen the randomized control data. So what I'm going to present to you is a 1,000 consecutive unselected experience from a single center in Stockholm, Sweden. So these are my conflicts. So these were the setups. So we included in this study all TAVR procedures that were performed at Karolinska between May 2017 and September 2020. And that comprised of 1,048 patients. 48 patients were excluded from the analysis, mainly due to non-femoral access. So major vascular complications in these 1,000 patients occurred in 4.2% of the cases. So this is a true all-comer study. It's 1,000 unselected consecutive patients. No other closure device was used during this study period. And during this study period, we had a 97% transfemoral access. So if you look at the patient characteristics, and I've divided it up here. So on the left-hand side, you see the patients without major vascular complication, and on the right-hand side, the patients with major vascular complication. And as you can see, these are the typical TAVR patients that we still see in our practice today, and there are actually no differences in the baseline characteristics in these patients. So we don't see predominantly females, for example, in this analysis. So if we then go back and check on vessel size, so the vessel sizes did actually also not significantly differ between the complication and non-complication group. There was a trend towards a little bit of a larger sheets being used in the complication group, and if you combine these two into a ratio, a sheet outer diameter to femoral artery inner diameter ratio, there is actually a significant larger ratio in the group with complication. Again, vessel anatomy, calcification, so skin to artery depth and also the high femoral bifurcations did not influence the outcome. There was a trend towards more anterior femoral artery calcifications in the complication group. And this trend was a little bit stronger if you look at the patients that had both anterior and posterior femoral artery calcifications. However, this did not reach statistical significance. So what about preoperative antithrombotic treatment? So there were actually absolutely no difference between the two groups, no matter if you were on NOAC or warfarin or aspirin. Basically the same outcomes. Not even if we look at the patients with an INR above 1.5, could we see an increase of complications. So what were then the type of complications that we saw in this registry? It's basically very similar to what you have seen in the randomized controlled trials. So the most common vascular complications that we saw was a need for a covered stent due to bleeding. At the beginning of the study, we could see that more of the complications were treated with surgical treatment. So we have quite a bit of that as well in our complications. However, as the study progressed, more and more of the complications were actually treated percutaneously. And now in our practice, it's very, very rare that we call the surgeons to fix our complication. We had one case of embolization of the device. So outcomes. So there were in the group of complications, there was an increased need for transfusion. So we had an increase of drop in hemoglobin, and this also translated to an extra day in the hospital, basically. So 3 compared to 2 days mean hospital stays. But more importantly, we could actually see no increase in 30-day mortality in the group with vascular complication, actually 0 in this analysis. Learning curve. We heard also from the randomized controlled trial that it's probably a quite short learning curve with the device, and we could also show this. If we analyzed our first 100 MANTA device procedures at our centers, there were actually no increase in complications. And also if we analyzed the 5 individual operators, their first 20 cases, we could also not see an increase in vascular complications, so indicating that there is a short learning curve with the device. So to conclude, so in this 1,000 consecutive, completely unselected cohort of patients undergoing transfemoral TAVR, we could show that the MANTA device is safe and effective. And also the majority of the complications were bleedings and occlusions that could be treated percutaneously in the cath lab. The only independent predictor for vascular complications were sheath to outer diameter to femoral artery inner diameter ratio. And also there were no increased 30-day mortality in patients with major vascular complications. And finally, this study indicates that the device is easy to use and also a short learning curve. Thank you very much.